We are going to discuss today the subject syncope. Usually you are used to pronouncing it as syncope. It is not correct. Syncoptein. Syncoptein is a Greek word. From the syncoptein, the word syncope is derived. Syncope. Syncope. Syncope is the pronunciation. What is syncope? Syncope is a common symptom, very common. Fainting, common faint, often with dramatic consequences. It looks very dramatic. Somebody suddenly falls on the ground. In the majority of the cases, it is benign, but in some cases, it may be very fatal. That is why we need to separate the benign syncope from the fatal syncope. So, it deserves thorough evaluation and appropriate management of the etiology. So, that goes without saying. There are a few competent physicians. There are a few competent physicians who do not experience slight syncope if their patient complains of giddiness. Means what? The patient comes with giddiness, then we have to be very careful because we also feel giddy because cause is not obvious. We have to evaluate. Let's skip this. Transient loss of consciousness. Syncope is a transient loss of consciousness, TLOC. The only difference between syncope and sudden death is that in the former, that is in the syncope, we wake up and never in the later. Now, the clinical presentation of transient loss of consciousness. The first question is there loss of consciousness? If there is no loss of consciousness, then it may be an altered consciousness or patient may have fallen suddenly due to some other reason, not because of loss of consciousness. Suppose there is loss of consciousness, yes, and is it transient or is it persistent? Transient means very quickly he recovers, rapid in onset, short duration, spontaneous recovery is what is defined as transient loss of consciousness. If it is not transient loss of consciousness, then patient may have coma, an aborted sudden cardiac death, or other causes which have caused the loss of consciousness, which is not transient. Then the next question is, once it is transient loss of consciousness, is it precipitated by trauma? Following a trauma it occurred, or it is atraumatic or non-traumatic? So how did we come here? Is there loss of consciousness? Yes. Is the loss of consciousness transient? Yes. Is there a history fall? No. That is the non-traumatic transient loss of consciousness. If it is non-traumatic, then of course trauma is the cause. Somebody dashes against a wall or a glass door and then he faints and falls. That is traumatic loss of consciousness. Non-traumatic loss of consciousness can be one of the four. One is syncope, the other one is epileptic seizure, the third one is psychogenic, and there are other rarer causes. Now, we have to understand whether our patient fits into first loss of consciousness, then transient loss of consciousness means rapid in onset, very short duration, spontaneous recovery, and transient symptoms. Non-traumatic, we are dealing probably with epilepsy or syncope or psychogenic disorder or rarer causes. Now, let's go further. There are three terms in our clinical examination. One is syncope, the other is vertigo, the third one is gait ataxia. Gait ataxia means if you ask the patient to walk, he staggers and he stutters and he falls and not able to do it, provided there is enough power in the lower limbs, ataxia can be elicited. That is simple. Patient doesn't have any loss of consciousness. His gait only is ataxic. There are several types of ataxia, cerebellar ataxia, sensory ataxia. Ataxic gaits are various types are there, which is not the subject of today's talk. We will take up ataxia as a separate topic. Now, vertigo is spinning of the objects around or spinning of himself around the objects. Subjective sensation of spinning or objective sensation of objects spinning is vertigo. There is no loss of consciousness in vertigo. Then we are now dealing with syncope. What is the basic difference between them? In syncope, there is loss of consciousness. In vertigo and gait ataxia, there is no loss of consciousness. Vertigo may last for minutes, syncope lasts hardly for a minute. Gait ataxia is persistent whenever he tries to walk. It is not transient, it is persistent. Now, let's go and look at the details. Classification of transient loss of consciousness. Okay, so disorders mimicking syncope, these are called mimics or syncope itself. Syncope may be mediated neurologically, orthostatic hypotension, cardiac arrhythmias, structural heart disease, SHD. Hereafter we call structural heart disease like aortic stenosis or obstructive cardiomyopathy or some structural diseases there. Cardiac arrhythmias is the other important classification. And then you have postural hypotension, also called the orthostatic hypotension, and neurologically mediated reflux syndromes. These are the four main types of syncope. Disorders mimicking syncope with loss of consciousness, without loss of consciousness. With loss of consciousness may be seizure disorder, may be a cerebral concussion due to sudden injury that could be there. Without loss of consciousness, psychogenic causes, also called the pseudosyncope. Okay. Syncope is not a diagnosis. Anemia is not a diagnosis. Fever is not a diagnosis. Fever is a symptom. Anemia is a sign. And syncope is a symptom and not a diagnosis. We have to evaluate and find out the etiological diagnosis of syncope. Beware of less specific symptoms, and the patient may not have all the specific symptoms mentioned here. Loss of consciousness and postural tone. That means he feels as though he's dropping to the ground. The muscles are not supporting him. It's as though there is totally muscle tone is lost and then he falls to the ground. It is self-limited, relatively rapid in onset. Variable warning symptoms may be there. Some may experience pre-syncope. Most important differential diagnosis point is syncope is spontaneous, complete, and prompt recovery. You don't require a treatment for recovery, and it is not incomplete. Totally, the patient will be normal after the attack, and then immediately he or she gets up, prompt recovery. There are many causative issues. It is a symptom and not a diagnosis by itself. The underlying mechanism is definition or pathogenesis of syncope is transient global cerebral hypoperfusion. If somebody asks what is syncope, you should be able to say these 5 words. Transient, comes very immediate recovery. Global, not one part of the brain, entire brain is affected. It is cerebral, mainly the cerebrum, and hypoperfusion. Transient global cerebral hypoperfusion of various etiologies. So, what is the control? Normally, autonomic nervous system controls the body in such a way that we don't fall down when we have a fall of blood pressure. So there are high pressure mechanoreceptors and low pressure mechanoreceptors. If there is a gravitational shift of more than 1000 ml of fluid, or if there is an increase in the capillary pressure due to filtration, and that increases the filtration, reduced venous return to the heart due to various causes, decrease in the filling pressure of the ventricles, and systolic volume and cardiac output thereby, these can cause vasoconstriction to keep the tone. Neuroendocrine system checks are there, skeletal muscle pump is activated, respiratory pump activity is there, and syncope is prevented. In syncope, what happens? All these mechanisms are at fault. The skeletal muscle pump doesn't work, neuroendocrine feedback doesn't work, vasodilatation occurs, syncope or loss of postural tone develops. So, what are the controlling areas? Neuromuscular system, NMS, cerebral cortex, vascular bed, and cerebral cortex has got a feedback via the carotid baroreceptors and other mechanoreceptors. The baroreceptors are there in the carotid and the carotid body, and then the parasympathetic, it slows the heart, increase in the parasympathetic, produces bradycardia and slows the AV conduction, and increase in the sympathetic produces vasodilatation of the splanchnic vascular beds, and then there is vasodilatation. All these mechanisms result in two important things. One, bradycardia, two, hypotension, and this results in the fall and syncope. Now, this is a beautiful diagram to understand the etiology of syncope. Okay, you see the maximum colored area is the yellow colored one. That yellow colored one is syncope secondary to orthostatic hypotension. Syncope secondary to orthostatic hypotension. What are they? Number one, normal autonomic system. There is no autonomic failure. Autonomic system is properly working, but the drugs can induce autonomic failure. Autonomic system is normal, but drug-induced autonomic failure. There is a structural damage to the autonomic system, which comprises sympathetic and parasympathetic. This structural damage may be primary autonomic failure or secondary autonomic failure. Now, there is inadequate and impediment to the venous return. So much so the blood volume return into the heart is less. Why? Because of volume depletion or because of venous pooling. Let's say a soldier stands for an hour and a half in hot sun, there is venous pooling. In the school, when the children are made to stand up for prayer, one or two children drop to the ground because of venous pooling. And in hot weather, there is volume depletion. Okay. In hot weather, there is volume depletion also. So, the yellow area in this circle is secondary causes of syncope due to orthostatic hypotension. Orthostatic also called the postural hypotension. First is normal ANS and drug-induced autonomic failure. For example, you are using, certain antihypertensive drugs, particularly the amlodipine, things like that, or even alpha blockers, prazosin, doxycycline. These are the ones which are the alpha blockers. And the amlodipine group of drugs, they also produce autonomic failure. Normal autonomic system, drug-induced. Structural damage to the autonomic system, primary autonomic failure, secondary to diabetes or secondary to neurological disease. It can occur. Inadequate venous return because of volume depletion or venous pooling. And next important cause called reflex syncope. Reflex syncope, and then vasodepressor syncope, and then cardiodepressor syncope. Cardio inhibitory and vasodepressor, there is fall of blood pressure, there is fall of heart rate, there is no correction, inappropriate reflex, or there could be a mixture of cardio and vasodepressor syncope. That is called reflex syncope. Okay. Then we are left with cardiac syncope or cardiogenic syncope. Here, most important, there is a cardiac cause or a pulmonary cause as the underlying. Pulmonary cause like pulmonary embolism, cardiac arrhythmia, ventricular fibrillation, atrial fibrillation, runs of ventricular tachycardia, and then structural cardiac disease like valvular or congenital heart diseases or hypertrophic obstructive cardiomyopathy or other causes. These are all cardiac syncope. So basically, secondary or orthostatic hypotension and syncope, cardiac syncope, and reflex syncope. What is the central feature in all? Blood pressure is lower, heart rate is sometimes lower. This is transient, global, cerebral, hypoperfusion. So in this half, you can see there is a low peripheral resistance. Here, there is low cardiac output. The cause here is low cardiac output. The cause here is the low peripheral resistance. A very good summary diagram to understand various causes and mechanisms of syncope. Okay. The reported frequency in individuals less than 18 years, 15% of the patients have syncope. Military population, 20 to 25%, over 40 but below 59, 16 to 19%, and individuals over 70 years, around 1/4 of them will experience a syncope during a 10-year period. The significance of syncope. Some causes of syncope are potentially dangerous and may cause death. Cardiac causes of syncope have higher mortality rates. So recurrence occurs in about 34% in 3-year follow-up. That means if a patient had syncope, now the chances of he or she having another attack in 3 years is roughly 1/3. That means we have to evaluate and prevent the recurrence of syncope. The overall syncope mortality rate is less than 10%, taking all the causes into consideration. Supposing you take only cardiac causes into consideration, the mortality can be as high as 25%. See, 25% death rate in such an innocuous looking disease is very high. And that means if you have 100 patients of cardiac syncope, 25% of them die within 1 year, which is a very bad news. Okay. The mortality trends are given benign versus fatal. You have to know what is benign and what is fatal. You look at the red curve here, the lowest one, which has got the highest Kaplan-Meier curve. Kaplan-Meier survival curves will give you the mortality trend. The lowest one is this one, and this is due to the cardiac causes. The next lower one is due to the green color, neurological causes. The third one is unknown causes. The fourth one is vasovagal and other causes, and no symptoms are there, the best. That means cardiac causes produce greatest mortality, neurological causes are the second in rank, unknown causes are there, Then vasovagal causes less mortality. No symptoms are there, and they have the mortality is that much. So comparing to no symptoms, this is how low and high mortality, naturally mediated syncope versus syncope with structural heart disease. Okay. This is cumulative mortality in 2 years. Supposing you follow these patients for 24 months, the highest mortality, first of all, you have to divide the patient elderly, young. Elderly are at a greater risk. As you can see, this one and this one are elderly with cardiac disease, more mortality. Without cardiac disease, less mortality. In the young also, with cardiac disease, almost like elderly people without cardiac disease, in the young, the mortality is very low. What does this mean? This means if the patient is young, the mortality is low. If the patient is elderly, the mortality is high. If the patient has got cardiac cause underlying, the mortality is high. If the patient has non-cardiac cause, the mortality is low. If a patient is elderly and also has a cardiac cause, the mortality in 2 years is the highest. Now, impact of syncope on the quality of life. Not only it causes mortality and the quality of life. The patient of syncope always is anxious or depressed. Around 73% of them alter daily activities. They have to change their pattern. Restriction in their driving occurs in 60% of cases. No change in the employment, only in the 37% of patients. So this is how the quality of life is affected. Now, my fundamental task when I have a patient of syncope is it a benign disease or is it a serious disease? How do I know that? Is my patient having benign syncope or a serious syncope? We need to reconstruct the story. You look here, 1 year mortality with cardiac causes is around 20 to 30%. At least 1/3 of them will disappear by the end of 1 year. The cardiac cause is the underlying mechanism for the syncope. Unknown causes, mortality rate is 6%. Non-cardiac causes, it is less than, it is 1% or 2%. Again implying the age and cardiac etiology will be very important for 1 year mortality as well as morbidity. So cardiac reasons also are more pronounced in the elderly. That's the elderly with cardiac disease are at the highest risk. So what are the various broad categories? The broad categories are non-CVS, cardiac arrhythmias, pulmonary hypertension, sudden structural heart disease, orthostatic hypotension, idiopathic, vasovagal or neural reflex. Neural reflex stands out prominently because that is the common cause. Vasovagal syncope is the commonest cause. Non-CVS other causes are there. CVS causes are arrhythmias and structural heart disease and pulmonary hypertension. Under the non-CVS, we have several other reasons like drugs, autonomic failure, and all that. Orthostatic hypotension. We have seen what are the causes of orthostatic hypotension. In spite of all the evaluation, some patients we will not be able to diagnose what is the underlying cause. Such cases are idiopathic. Out of all these, neural reflex or vasovagal syncope is the predominant one. Now you see, whatever you do, we cannot find out a cause in 35% of the cases. Only in 65% of patients, we will be able to unearth the underlying cause. Neurally mediated, 24%, orthostatic due to drugs or autonomic failure, primary or secondary, 11%, and neurally mediated vasovagal, carotid sinus, situational cough, micturition, law of syncope like that, cardiac arrhythmias, bradyarrhythmias, sick sinus, AV black, tachyarrhythmias, ventricular tachycardia, supraventricular tachycardia, long QT syndromes, they account for 14%. Structural heart disease or lung disease, pulmonary hypertension, hypertrophic obstructive cardiomyopathy, aortic stenosis, severe aortic stenosis, 4%. Psychogenic, metabolic, hyperventilation, neurological causes are 12%. So again, emphasizing that neurologically mediated, non-CVS causes, orthostatic hypotension are major causes of syncope. Structural heart disease, cardiac arrhythmias constitute around 20% of the cases. Disorders of the vascular tone and blood volume. First group is disorders of the vascular tone and blood volume. First one is vasovagal, also called vasodepressor syncope or neurocardiogenic syncope. The second one is postural hypotension, also called as orthostatic hypotension. The orthostatic can be due to drug-induced. Majority of the antihypertensive drugs, they produce postural hypotension, thus cause syncope. Peripheral neuropathy, diabetic neuropathy, alcoholic neuropathy, or idiopathic postural hypotension. Okay, disorders of the vascular system, vascular tone and blood volume, vasovagal, postural hypotension, carotid sinus hypersensitivity, CSS, carotid sinus syncope, anemia is a very important and common cause of syncope. We have seen many patients complaining of syncopal attacks, and then when we evaluate, the cause is underlying severe anemia. Situational, like cough, some patients, when they have bouts of cough, they get syncope. And some patients, when micturition, they will develop. Some patients, when they see blood being taken or being bled, or there is a bleeding due to trauma, they faint. That is also syncope. Valsalva maneuver, that is, blowing the air out forcibly after closing the nostrils. Like that, close nose and mouth and try to blow the air forcibly. That is called Valsalva maneuver. That can precipitate syncope. Syncope in some. Glossopharyngeal neuralgia, trigeminal neuralgia can produce syncope. Disorders of vascular tone or blood volume, vasovagal, postural, carotid sinus, situational, and neuralgias. Now, then is cardiovascular. Cardiovascular, bradyarrhythmias, sinus bradycardia, sinoatrial block, sinus arrest, sick sinus syndrome, atrioventricular block, decreased LV ejection function due to whatever is the cause. Maybe myocardial infarction, maybe LVH and hypertension, maybe many causes of decreased ejection fraction. Then tachyarrhythmias like supraventricular tachycardia, atrial fluid fibrillation, atrial flutter, and ventricular tachycardia. Other cardiopulmonary causes, pulmonary hypertension, pulmonary embolism. And then massive myocardial infarction may suddenly produce an attack of syncope. Left ventricular restriction or constriction due to aortic valve stenosis or hypertrophic obstructive cardiomyopathy. These are various cardiovascular causes. First one is vascular tone and blood volume, under which vasovagal, postural, carotid sinus, situational, and neuralgic, and then cardiovascular causes we have seen. Now, specific conditions are brady and tachyarrhythmias, long QT syndrome, torsade de pontes. I will show you what it is. Brugada also I will show you, and induced drug induced. Brugada may be a short notes, torsade de pontes may be short notes, long QT syndrome itself can be a short notes, and QT interval prolongation can be a short note question. Structural cardiopulmonary disease, neurally mediated vasovagal syncope, carotid sinus syndrome, orthostatic anemia is an important cause. A diagnostic plan is essential to diagnose this particular condition. Okay. Initial examination, monitoring, cardiac imaging, special investigation. What do I do in the initial examination? Detailed patient history, physical examination, an ECG, supine and upright blood pressure. This is to assess the postural hypotension. Monitoring, we have a 24-hour Holter or 48-hour Holter, event monitors, insertable loop recorders are also there, ILR. Cardiac imaging, special investigation. Cardiac imaging includes echo and transesophageal echo, and then other modalities of cardiac imaging. Special investigations, head-up tilt test, also called the HUT test, head-up tilt test, HUT test, hemodynamic studies, electrophysiological studies to know the pattern of the anemia, and pattern of the arrhythmia, and EP mapping, and ablation. Initial examination, detailed patient history is very essential. What are the most important things? The situation and position in which the syncope has developed. Activity and neck movements at the time of, is it precipitated after sudden neck movements, after any playing or anything? Prodromal symptoms, whether any nausea, giddiness, dizziness, vomiting, pre-syncopal symptoms. Somebody is the eyewitness for the incident. You have to call them and ask them what exactly has happened. The manner of fall, whether the patient suddenly drifted onto the ground or slowly he just lost balance and then settled on the ground. Skin color and sweating. Is there sweating? What is the skin color? Is it paler, or is it ashen gray, or is it ruddy? Jerky movements of the body, like any convulsions or any partial tonic-clonic convulsions. What is the bladder control? Is there any tongue biting? We have to see. Post-syncopal period, how is the patient after the attack? History of any medications, particularly hypertension medications, concomitant diseases, especially cardiac disease, pertinent family history related to cardiac disease, sudden cardiac death in the family members, and metabolic disorders. Past medical history, neurological history, and previous history of syncope also is very important. Thorough physical examination is essential. One is heart rate, two is orthostatic blood pressure change, three is cardiovascular examination. Is there a heart disease? ECG is essential. Long QT interval, pre-excitation, WPW syndrome, conduction defects are there. Echo, depressed LV function, valve status, hypertrophic obstructive cardiomyopathy. Neurological examination for peripheral neuropathy, autonomic neuropathy, neurological diseases underlying causing neuropathy, carotid sinus massage. It is a special test performed. Carotid sinus massage performed under clinically appropriate conditions, preferably during the head-up tilt test. Monitor during the test both ECG and blood pressure. I'll tell you a little about the CSM later. This is the slide on the carotid sinus massage. So what do? This is feel the internal carotid artery and gently massage with your thumb 5 to 10 seconds on the carotid artery. Do not occlude the artery. Do not be vigorous on the massage. Patient can be supine or upright posture on the tilt table. If he is supine, no problem. If he is tied to the tilt table, he can be upright. Then, what is the outcome? What should I look for after the 5 to 10 seconds carotid massage? 3-second asystole may be there. That means there is no contraction of the heart for 3 seconds. Or there is a 50 millimeter fall in the systolic blood pressure with reproduction of the earlier symptoms. That is called CSS, carotid sinus syndrome. I'm again telling, ask the patient to lie down on the bed, Or if he is upright, he should be on the tilt table, tied with the belt, so that he won't fall to the ground. Massage on the carotid sinus for about 10 seconds. Don't occlude the flow, nor don't squeeze the carotid too much. Then what is the test endpoint we see? Is there an asystole? Keep feeling the pulse and keep watching in the monitor. If there is an asystole for more than 3 seconds, usually in 3 seconds we expect 4 beats to occur. They are not occurring, then naturally there is asystole. 50 millimeters fall, 50 or more fall in the systolic blood pressure, and patient experiences the symptoms he had during syncope. That is a positive carotid sinus test. When I should not do this particular test? Absolute contraindication. When you hear a carotid bruit, means there is carotid artery stenosis. Known significant carotid arterial disease, previous CVA, cerebrovascular accident, myocardial infarction in the last 3 months, cerebrovascular accident, myocardial infarction in the last 3 months, carotid arterial disease, and known case of carotid bruit. We don't do a carotid sinus massage. What are the complications? Primarily neurological. Less than 0.2% of people develop weakness of one or both sides of the body. Usually it is transient. Carotid sinus syndrome, CSS, with CSM test may be itself a short notes. Other diagnostic tests. What are the other things I need to do? Ambulatory ECG, Holter monitoring, 24-hour Holter or 48-hour Holter, event recorders, intermittent event recorders versus loop recorders, insertable loop recorders called ILRs, head-up tilt test includes drug provocation using isoproterenol or nitroglycerin, carotid sinus massage, adenosine triphosphate test, and electrophysiological mapping, also called the EPS. So if a patient presents with syncope, these are the following investigations. Ambulatory ECG, Holter monitoring, if necessary, event recorder, intermittent versus insertable, head-up tilt test, drug provocation, carotid sinus massage, adenosine triphosphate test, and electrophysiological studies if you are suspecting cardiac arrhythmia. Now you see how long each one records the ECG. If you take a 12-lead ECG, it just captures 10 seconds of the heart rhythm. If you have a 2-day Holter, then it monitors for 2 days. Event recorders can record up to 30 days, 7 to 30 days. These are non-lead and loop type of event recorders. So ERs are there. And finally, insertable loop recorders, ILR, they can be in the body up to 14 months, and they record the events as and when they occur. This is the head-up tilt test or HUT test. The protocols vary. What you do is you take the patient in the supine position on the table first like this, and then tie him with the belt here, and he is secured onto the onto the belt, onto the table, using belts in the chest, belts near the abdomen, belts near below the thigh regions, and also possible here also. There will be belt and you tie the patient. Then machine his feet are landing on the rest here. Okay, so that he will not be hanging on the table and he is rested on the foot rest there. And then once you tilt the table to around 60 to 80 degrees, slowly, then you have to ask the patient whether he experiences symptoms of syncope and what is the blood pressure and what is the heart rate. Is there any asystole? Useful diagnostic adjunct procedure, useful for teaching patients to recognize the symptoms. If you do the test, if he gets the symptoms, patient knows these are the symptoms. When at home, if he gets the symptoms, he will be alert and then take a seat or lie down. This is not useful as a follow-up for treatment. You start treatment, you can't use HUT test to say whether the patient is improving or not improving. So what is it used for? It's a diagnostic test in atypical cases of syncope, and it also makes the patients experience, teaches them the prodromal symptoms. It is not useful for assessing the treatment. It's not useful for assessing the treatment. Okay. This is how the test is done. You can see the patient is belted onto the couch there, and he resting on the feet, tied here, rubber bands are there, very nicely secured. And this is how the bed looks, when with the belts there, and unmasks the vasovagal susceptibility, reproduces the symptoms. Patient learns the warning symptoms. Physician is better able to give prognostication and treatment advice. So patient is first kept in the position, and there is a tilt slowly up to 60 degrees to 80 degrees tilt we can do. So diagnostic assessment, what is the yield I get? Positive response we get. History, physical examination, ECG, corrected sinus massage, 30 to 38 to 45% positives we get. Head up tilt test, heart test, 27%. External cardiac monitoring, 5 to 13%. Insertable loop recorder, of course, captures a lot of this one, but these are not available everywhere. Electrical mapping study, useful in case of arrhythmias. Exercise test is not indicated because it doesn't give much of information. EEG is also only when you are suspecting a sort of seizure disorder, otherwise not required. CT MRI of the brain is not advocated and not useful. So what are the most useful things? History and physical examination, routine ECG, carotid sinus massage, heart test, cardiac monitoring, ILR, very useful test. Now, I need to differentiate seizure disorder from syncope. How do I do that? The onset in seizure is sudden and syncope is more gradual. Duration seizure in minutes, syncope the duration is seconds. 30 seconds, 50 seconds, 60 seconds. Their seizure will be 1 minute, 1.5 minutes, 2 minutes to 5 minutes also. In status, it will be even larger. Jerky movements are very frequent in seizure, they are rare in syncope. Okay, headache is frequent after the seizure, and occasionally syncope also may have headache. Confusion, post-ictal in confusion state is present in the seizure, is very rare in syncope. Unconsciousness may last more than 5 minutes in case of seizure. Usually it is very short, less than 1 minute in syncope. Incontinence of the bladder and bowel, very frequent. In syncope, very rare. The patient says, I had a fall and I had lost my bladder control, and it lasted for more than 5 minutes, and there is jerky movement of the body. Most likely it is seizure disorder. High deviations, horizontal high deviations, if at all it is there, vertical high deviation will occur. Tongue biting is frequent. Tongue biting may not occur in syncope. Prodromal aura, epileptic aura are there. Here prodromal dizziness may be there. EEG, often abnormal. Usually EEG is normal in syncope. This is how I differentiate seizure disorder from syncope. Differential diagnosis of seizure versus syncope. Now, serious tests like head CT and MRI are not required, not routinely used for syncope. May help only to diagnose the seizure disorder. Otherwise, they are rarely diagnostic for syncope. Now, algorithmic approach. Now, we have a patient with syncope. There are abnormal physical findings, no abnormal physical or history. History is normal, no abnormal physical findings. Most likely vasodepressor syncope. Use the heart test and then confirm that it is vasodepressor. Suppose patient has abnormal symptoms. abnormal history and physical examination. Is it a cardiac disease or cardiogenic syncope? So cardiac disease, what you require is an ECG, echo, and EP mapping to find out the underlying cardiac disease and cardiogenic syncope. Okay. So if the patient has got no abnormal physical findings, but no cardiac disease, he has got orthostatic hypotension, central nervous system abnormality, peripheral nervous system abnormality, review the medications, particularly BP medications, CNS diseases like multiple sclerosis, peripheral nervous system, diabetic polyneuropathy, and other polyneuropathies are there. So this is an algorithmic approach to diagnosis. Differential diagnosis of mimics, syncope mimics. What are syncope mimics? Anxiety disorder, panic attacks, hyperventilation syndrome, drop attacks, seizure disorders, sleep disorders like narcolepsy and cataplexy. Hypoglycemia is a very common and important differential diagnosis. Acute alcohol intoxication, acute hemorrhage, trauma, cerebral concussion, hysterical fainting, vertebrobasilar insufficiency, transient ischemic attack. These are differential diagnoses of syncope. Internal hemorrhage, myocardial infarction, cardiac arrhythmias are emergencies which need immediate admission and prompt treatment, otherwise the outcome will be fatal. In internal hemorrhage of the brain or myocardial infarction or cardiac arrhythmias, they demand emergency admission and treatment. What are the management questions? What is my best diagnostic test? How and when I rule out arrhythmia? How to diagnose neurogenic cardiogenic syncope? How to decrease the proportion of those without any cause? When do I admit a patient? Is there a structural underlying heart disease? How are the elderly patients different? When to resume driving? These are some of the management dilemmas. What do you have to do? Keep the patient in the supine position, head tilted to the one side, nil oral. Don't ask him to drink Coca-Cola, fruit juice, coconut water, nothing. So because when he is unconscious, sometimes the fluid may be aspirated into the respiratory tract and produce aspiration pneumonia. So nil oral, cold water sprinkling on the face can be done. Orthostatic hypotension, you have to advise the patient to raise from the lying down position to sitting position, 1 to 2 minutes, sitting to standing, 1 to 2 minutes, standing to walking, 1 to 2 minutes. Slow raising is important. General measures, cause specific, avoid postural hypotension, avoid venous pooling, and salt replenishment is important. What are the drugs that I have to improve the syncopal attacks? Scopolamine, diazopyramide, CBZ, that is carbamazepine, metadrine, etilfrine, antiarrhythmic treatment, EP mapping, ablation of the abnormal pathways, and if necessary, pacing are the treatments. Now, vasovagal syncope, clinical pathophysiology, neurally mediated physiological reflex mechanism has two components. One component is cardio-inhibitory component. Heart rate drops to less than 50. Vasodepressor component, where the blood pressure systolic drops less than 60 millimeters. Despite there being heartbeats, there is no significant blood pressure generated. They are not effective contractions. Both components, decrease in the heart rate, decrease in the blood pressure, both are observed. So incidence of VVS around 8 to 37%, mean 18%. Most common form of syncope depends on the population. Young without heart disease, more VVS. Old with structural heart disease, less of VVS. In general, VVS patients younger than the carotid sinus syndrome patients. Ages range from adolescents to older adults, median age is 43. General treatment measures, optimal treatment strategies for VVS are these are source of debate, acute intervention, physical maneuvers like crossing the legs and squeezing will improve the venous return. Particularly, when you are sitting for long hours, it's always a good idea to cross the legs and squeeze, and also to paddle the ankles, lowering the head and keeping like this, when you feel dizzy, lowering the head or lying down, long term prevention, tilt training, education, diet, fluids, salt. At the bed, they can have a support hose. When they get up, they can use the hose to get up so that they don't fall, drug therapy, and cardiac pacing. Tilt training protocol, you ask the patient daily upright position against a wall. Start with 3 to 5 minutes morning and evening. Slowly increase to 30 minutes of training of standing upright close to the wall. Pharmacological treatment, fludrocortisone, beta-adrenergic blockers, and then SSRIs, selective serotonin reuptake inhibitors, we can use. Okay, and then vasoconstrictors like epinephrine and midodrine can be tried. Epinephrine as IV drip, epinephrine IV drip 1 to 8 mg, midodrine 2.5 to 10 milligrams TID, fludrocortisone 100 micrograms OD. Midodrine versus VVS. The midodrine for VVS has a fluid restriction, a fluid supplementation. Midodrine improved a lot. Carotid sinus syndrome. This is the second type of the vaso combination of neurovascular, neurocardiac, this one. Syncope clearly associated with carotid sinus stimulation is rare. CSS may be an important cause, unexplained syncope, and falls in the older individuals, sometimes stretching the neck, shaving the neck, or tight collar and tight winter wear can produce it. Prevalence higher in the previously believed. Carotid sinus hypersensitivity may be there. There may be no symptoms, and there is no treatment for this. The etiology is sensory nerve endings in the carotid sinus walls, or they respond to deformation. Deaffermation of the neck muscles may contribute. Increased efferent signals to the brainstem, reflex increase in the efferent vagal activity. Vagal is a depressor nerve. Heart rate falls. Diminution of sympathetic tone results in both bradycardia and vasodilatation. Bradycardia because of the vagal tone increase, and vasodilatation because of sympathetic stimulation. Follow blood pressure more than 50 mm and pauses or asystoles of more than 3 seconds is a diagnosis of CS. Orthostatic hypotension, very common, drug-induced. Diuretics are no excessive use of diuretics, vasodilators, calcium channel blockers, alpha blockers, not rejosine, daxijosine, like that. Clonidine, hydralazine, even ACE inhibitors, first dose hypotension. Primary autonomic failure due to multiple sclerosis, Parkinsonism, POTS, POTS, postural orthostatic tachycardia syndrome. This can be a short notes. POTS can be a short notes. Secondary autonomic failure may be due to alcohol, amyloid, diabetes, adrenal insufficiency, sudden steroid withdrawal. Internal bleeding can also produce orthostatic hypotension. So what do you do? How do I test for orthostatic hypotension? Ask the patient to be for 5 minutes in the supine position. So he has to sleep on the bed for 5 minutes. Then he has to stand for 3 minutes and observe the blood pressure. A drop in the systolic of more than 20 with or without symptoms is diagnostic of orthostatic hypotension. Normally, there is a 10 millimeter fall when you stand up compared to when you lay down. That is not orthostatic. Must be at least more than 20 millimeters with or without symptoms. And test must be performed not for half a minute, 3 minutes standing after 5 minutes of supine position. This is to elicit the orthostatic hypotension. Treatment strategies, patient education, injury avoidance, hydration, fluids, salt, diet, hot water, avoid hot water baths, minimize caffeine and alcohol, which are vasodilators, sleeping with the head end of the bed elevated, tilt training, leg crossing, arm pulling, like this, and then support hose, drug therapies, fludrocortisone, midodrine, erythropoietin to improve the anemia, tachypacing not probably useful. The drug doses I have already told you. Cardiac syncope includes cardiac arrhythmias and structural heart disease, often life-threatening, may be warning of a critical CV disease, tachy and bradyarrhythmias, myocardial ischemia, aortic stenosis, pulmonary hypertension, aortic dissection, subclavian steal syndrome. Access culprit arrhythmia, assess for the arrhythmia, and structural abnormality, initiate treatment. Syncope due to structural cardiovascular disease, acute infarction, hypertrophic cardiomyopathy, acute aortic dissection, pulmonary embolism, valvular abnormalities like severe aortic stenosis or tight mitral stenosis are very important. Syncope due to cardiac arrhythmias, brady and tachy. Under the brady, sinus arrest and exit block, high grade or acute complete AV block, and can be accompanied by vasodilatation along with VVS and CSS. Tachyarrhythmias usually AFib or A-flutter, and then rapid ventricular rate, peri-excitation syndromes like WPW, paroxysmal supraventricular tachycardia, ventricular tachycardia, torsadia despontis. We will see, and atrial arrhythmias and ventricular arrhythmias, AVNRT, AVRT and AVNRT, reentrant, non-reentrant tachycardias, atrial fibrillation, ventricular tachycardia, torsadia depontis, and prolonged QT. This is the torsatus depontis. So the ECG, there will be, these are ventricular beads, they are bigger beads and then smaller ones, again bigger ones, and again smaller ones. So the ventricular recording looks like a party streamer. Polymorphous ventricular tachycardia also simulates torsatus depontis. So QT interval is important. You have to measure the QT interval from the beginning of the Q wave to the end of the T wave. And this is the RR interval, R to R, the QRS complex. Corrected QT interval is QT interval divided by square root of the RR interval. Maximum QT interval should be 0.44. Anything more than that is prolonged QT interval. So you see in this ECG, so that is the starting point of the QT interval, that is the ending point. And we do that, we get an answer that it is 0.56. We told it is 0.44 is the upper limit, is the prolonged QT interval. The rule of thumb is take this RR interval. QT interval should not be more than half of the RR interval. If the RR interval is 0.8 seconds, QT interval should not be more than 0.4. It should be less than 0.4. If the RR interval 0.6, that is tachycardia, then the QT interval of 0.3 itself is prolonged QT interval. Okay. Long QT syndromes are important. Abnormalities of sodium and potassium channels, susceptibility to polymorphic ventricular tachycardia, drug-induced forms are there, genetic forms are there. These are called the LQTS, long QTS syndromes. Then the treatment is suspect them, emergency treatment, intravenous magnesium has to be given. Pacing is important. ICD, that is, pacing devices and intercardiac devices are important. Now, Brugada syndrome is very important for you to know. It may be a short notes. Look at the ECG. There will be prolonged PR interval. PR interval is more than 0.2 seconds. There is an RBB, right bundle branch block, and ST elevations can be seen in V1 and V2. So patient presents a prolonged PR, RBB, ST elevation, and the V1, V2. Usually in men, it is Brugada syndrome. Now, insertable loop recorders, you insert the loop recorder between the first and the fourth rib onto the left side of the chest. And this insertable recorders record for a long period. It looks somewhat like this. The insertable recorder called Reveal Plus, and then that is inserted into the body and it records. The ILD records are available for over a period of time. And now conventional EP testing also is required. The sinus node reaction time is more than 3,000 milliseconds. Corrected sinus node time is more than 600 milliseconds. These are special tests to diagnose the the cardiac disease due to sinus nodal dysfunction. Hospitalization recommendation: suspected or known significant heart disease, you admit him. ECG abnormalities suggesting potential life-threatening cause, you admit. Syncope occurring during exercise, you admit. After an accident or injury, you admit. History of premature sudden death in the family, not in him. Because if he has premature sudden death, he will not come and tell you again. In the family, then you have to admit. Now, when can I say a patient has good prognosis? Age is younger, ECG normal, psychiatric illness is there, and then neural cause is identified. When I say age is more than 45, abnormal ECG, structural heart disease, arrhythmia, recurrent syncope, poor prognosis. Now, this you have to remember. Chess. Chess is CHF, hematocrit less than 30, ECG abnormal, shortness of breath, and systolic blood pressure less than 90. This is called chest of syncope. C is CHF, H is hematocrit less than 30, E ECG abnormality, S shortness of breath, S systolic blood pressure less than 90. Then this is a San Francisco syncope rule to predict serious outcomes. If he has got chest, any one of these things, you have to admit him. The prognosis is poor. Now, the myth is every syncope patient needs to be admitted. No. Establish clear goals and admit only those which I have told you in the previous slide. So these are only the ones who require admission. Not everybody requires admission for syncope. Every syncope patient requires to rule out MI. No, admission not necessary. With careful history and normal EKG, you can exclude MI. Telemetry improves outcomes. Now, 1 year mortality is not affected by telemetry. So I'm skipping these cases for want of time, and I will circulate the PDF to you so that you can look at those cases and yourself you can understand. So thank you all very much.